Program Manager and Cancer Program Coordinator for Legacy Cancer Institute. And we are just thankful that you are here and willing to share part of your evening with us. So it's officially fall, which just happens to be my favorite time of year. But it's also an important season for other reasons, like it being breast cancer and gynecologic cancer awareness months. September and October represent both of those. So we are here on the eve of the 2022 fall equinox to not only mark the transition in seasons, but to raise awareness about women's cancers. So tonight's webinar is entitled The 3 W's of Breast and Cervical Cancer Screening, taking a look at the when, the why, the what, and it will feature presentations by Dr. Carrie Thomas and Dr. Julia Feniger. We are so fortunate to have them sharing their expertise with us this evening. So a bit about the speakers. Dr. Carrie Thomas was born and raised in New Mexico. She moved to Portland to complete her radiology residency at OHSU in 2008, and then completed a fellowship in women's imaging also at OHSU. Since completing her training, she has worked at Legacy Good Samaritan Breast Health Center. Dr. Julia Feniger is a fellowship-trained gynecology oncologist. She is an East Coast gal. She currently works at Legacy Health, but her path to get here has included completing medical school at the University of Michigan, her residency at the University of Chicago, and her fellowship at New York University. She has been in practice since 2013. So before I pass the baton to Dr. Thomas, just a bit of Zoom housekeeping. All of you will remain muted and your cameras off for the duration of tonight's webinar. I encourage you to use the chat box to post any of your questions. We will have a 15-minute or so time frame for Q&A after both speakers have presented. And then just as a gentle reminder, the scope of tonight's webinar is to provide you all with a broad wealth of knowledge, and we unfortunately aren't going to be able to offer really specific recommendations or answer individualized questions. And I will do my best to make sure that all of your questions get addressed, or at least as many of them as possible. So without me just chatting away the whole hour and 15 minutes, I am ready to pass the baton, and I welcome Dr. Carrie Thomas.
Hi, I don't have a camera, but this is what I look like. So I'm going to talk about breast cancer screening recommendations. Okay, so broadly, breast cancer is unfortunately just a very common disease. The statistical likelihood of getting breast cancer is 1 in 8 women, so just unfortunately super common. Risk factors include having a first-degree relative, like a mother or a sister with breast or ovarian cancer, any family history of male breast cancer, or family members with bilateral breast cancer. Those are also significant risk factors. Any history of a prior biopsy that showed atypia, for instance, is also going to raise a person's risk for developing breast cancer in the future. And then obviously genetic mutations tremendously raise a given patient's risk. The most common are BRCA1 and BRCA2, but there's a whole bunch of other ones that we know about now. The panel testing now includes about 80 different known mutations that can increase breast cancer risk. And so if someone is concerned about their risk, given their family history, a genetic counselor might actually test for many, many, many other mutations than just those 2 common ones. Another big risk factor is having had radiation, typically for lymphoma, to the chest before the age of 30. And then there's also a small increased risk just from having dense breast tissue, but we'll talk about that in a moment. And just of note, when we talk about family history, it's just important to remember that both maternal and paternal family history matter. So it's not just mom's side, it's actually both sides that we take into consideration. Regarding breast density, since 2014, the state of Oregon has had a law that all imaging centers need to tell patients what their breast density is and to make sure that patients understand that having dense tissue can increase your cancer risk. It's about twice the relative risk from the background population. And if someone does have dense tissue, we do offer supplemental screening with ultrasound that they can discuss with their doctor. So the most important thing is if you get a notice that you do have dense tissue, just talk about that with your doctor to see whether you should pursue any additional screening. Breast density just means what your tissue looks like on a mammogram. It's not a measure of how the breasts feel or look on exam. And it really just describes the relative proportions of fat versus glandular tissue in the breast. So if you have dense breast tissue, you don't have as much relative fat in the breast. And lower breast density means more fat than glandular tissue in the breast. Typically, with age and after menopause, the density will decrease. And there's some data that it can also be decreased with a low-fat diet, that's not as well established. This is just an illustration of what it means to have dense breast tissue. So there's 4 different ways we grade density, from fatty, meaning very little glandular tissue, all the way to extremely dense, which is when the breast is almost all dense glandular tissue. And basically on a mammogram, these are all mammogram images of a left breast. White on the mammogram is glandular tissue, and the sort of grayer tissue in here is fat. So you can see this less bright breast is mostly fat, whereas this one is mostly white, which is very, very dense. And the issue with this is that cancers are also, they look like little white spots on a mammogram. So you can see how having dense tissue might obscure that. It's kind of like looking for a snowball in a snowstorm. So when we talk about defining risk, we just want to emphasize that each woman needs to understand her own risk of breast cancer to decide on how she should be screened. And we'll go over those in great detail here in a moment. And it's important just to know what your breast density is and know what your family history is. And that will really help figure out whether you're average risk or higher risk. So overall, only about 10% of breast cancers are related to family history or genetic mutation. So only about 10% are hereditary. Most of them are sporadic. There's a few risk factors that can increase the chances of a sporadic cancer, like early menarche, so starting your period when you're under the age of 12, or going through menopause a little bit later than average, like over 55. Whether you've had children or not can increase your risk of breast cancer. Specifically, if you have your first child after the age of 30 or none at all, that can increase risk of breast cancer a little bit. And even if you've had kids not breastfeeding, can also slightly increase your risk. There's some data that aromatic hydrocarbons in environmental exposures can increase your breast cancer risk, like coal, gas, oil. Burning the fumes from those things can increase your risk. Smoking is definitely a risk factor. And then in terms of just an individual lifestyle level, a lot of alcohol consumption can increase your risk. Being overweight and sedentary increases your risk of breast cancer, among other cancers. And then unhealthy diet lacking in fruits and veggies is also another risk factor. And we already discussed the risk of density, personal history of breast cancer, and having had prior atypical cells on a biopsy. So this is sort of the basic rule for screening recommendations is starting just broadly, everyone should start annual mammograms at age 40. And this is tremendously well studied. Decades and decades and decades of excellent data across multiple countries show that if we start screening mammograms at age 40, we can reduce breast cancer mortality by almost 39%. So that's tremendous. That just shows that when we find cancers earlier, we find them before they spread and they can be cured. Regular self-breast exams can also be helpful, although those aren't formally recommended. Annual professional breast exams are also a good idea. And then we'll go into additional imaging for higher risk patients. But basically for your average risk person in the general population, basically average risk women should start at age 40 doing a mammogram every year. It's also important, just speaking about risk factors, that you think about what your risk is or what a given patient's risk is before the age of 30, because we actually start screening in the mid to late 20s if people are really high risk. So especially people who have Ashkenazi Jewish descent and African American women should really try to talk to their doctor about their risk before the age of 30, because those populations are some of the highest risk for inherited mutations. Okay, so these are the sort of three primary things we use for screening for breast cancer. 3D mammography, that just means, we'll talk about what 3D means, but basically mammography is the gold standard and it finds around 6 to 8 cancers per 1,000 patients screened. Screening ultrasound can find about 1 or 2 more cancers per 1,000 patients who are already undergoing mammography. So it finds a couple more in addition to mammography, but not as many. Screening MRI is the highest sensitivity exam that we have, and that finds around 18 cancers per 1,000. So you can, if you look at these numbers, screening MRI by far and away finds the most cancers, but it's also the most expensive and most limited in supply. And 3D mammography is the best studied in the general population. And just to note, aside from screening mammography, there can be out-of-pocket expenses not covered by insurance with these additional screening modalities like ultrasound and MRI. So 3D mammography is also called tomosynthesis, and it's just a technique of doing mammograms where the machine acquires an image of the breast at multiple angles. It sort of does an arc over the breast, and then it takes those images and reconstructs them into a whole bunch of very, very, very thin slices that we can kind of scroll through. So it's like the pages of a book. And that has become the gold standard for mammography in the last decade or so. Previously, we would just acquire one image instead of multiple thin images. And by doing that, we can reduce the number of callbacks for extra views from screening, which also leads to like less anxiety. And it's also ultimately less radiation exposure by doing having fewer callbacks. And it also finds more cancers. So when we can look through really detailed thin slices of breast tissue, we can find tiny cancers that would otherwise be obscured. This is just one example of a conventional mammogram versus a 3D mammogram. And this is a fairly fatty breast, so it's not very dense. And this is actually a cancer here. And on the regular 2D mammogram, that doesn't stand out as much. But on the 3D mammogram, we can pick out just a single slice that really shows the spiculated mass, and there's actually some calcifications associated with it that you can really only see with this detailed thin 3D image. This is just an example of showing how much more visible cancers can be with this better mammogram technology. A really common question we get is, what is the radiation dose from mammography? And just keep this picture in mind. So basically, a screening mammogram is about the same radiation dose as you get from flying on an airplane from here to Paris and back. It's also about the same as living in Denver, Colorado for about 3 weeks. And that's just radiation from living at elevation. Anyway, some nice croissants here. So if you think about croissants and going to Paris, you know, that's about the same radiation dose as a mammogram. So very, very, very minimal. Okay, moving on to the next modality, screening ultrasound. So for people who have dense tissue, that really bright white tissue on the mammogram I was showing earlier, we do offer screening ultrasound in those patients, as long as they don't have other big risk factors like a genetic mutation, for instance, or a personal history of breast cancer. By adding ultrasound in addition to their mammogram, we can find 1 or 2 more cancers per 1,000 patients screened. And there's no radiation dose at all with ultrasound, but it is far less sensitive than MRI. At Good Sam, we actually have what's called automated breast ultrasound. And this is basically a big frame that fits over the whole breast. And there's an ultrasound transducer embedded in the frame, and it scans over the whole volume of breast tissue and sends that to the radiologist. So we get to review the whole volume of breast tissue as opposed to a conventional ultrasound like this little probe here, where just single images are saved by a technologist and sent to us. So we can actually, the radiologist, the physician, reviewing your exam actually gets to see all of the tissue using this technique. And this isn't available very many places right now, but we've had it at Good Sam since 2016. This is just an image of what a screening breast ultrasound looks like. This is a very dense breast, and these are actually nipple markers, these little yellow dots, and we've scrolled through the breast tissue. We're kind of midway through the breast on both of these pictures. These are ribs here, lung down here, and this is very normal breast tissue between the skin and the chest wall on both sides. Okay, so just to recap, for average risk patients, again, that's that sort of 1 in 8 lifetime risk of breast cancer. We recommend annual screening mammograms every year beginning at age 40. For people with slightly higher risk or intermediate risk, like for instance, having dense tissue, you still need to start annual mammograms at age 40, and you can consider adding screening breast ultrasound after discussing the pros and cons with your doctor. For very high lifetime risk patients, like over 20% lifetime risk, we'll go over those recommendations. But usually to get to this number of greater than 20% lifetime risk, you need some of these factors. So a history of chest radiation before the age of 30, having had breast cancer yourself or atypia or other high-risk lesions, or having a premenopausal breast cancer in a parent or sibling. So if a patient has had chest radiation at a young age before 30, we recommend they start annual screening mammograms at age 25 or 8 years after they finished completing their radiation therapy, so whichever is later. So for instance, if you had chest radiation at age 15, we'd recommend annual screening mammograms at age 25. Or if you had chest radiation at age 20, we'd say to start at age 28 with screening mammograms. If a patient has had breast cancer or atypia or a high-risk lesion on biopsy, we recommend that they continue annual screening mammography at the time of diagnosis, regardless of their age. So even if they were diagnosed at age 28, from there on out, they should do annual mammograms. And for patients who have a history of premenopausal breast cancer and a first-degree relative, we recommend that that patient begin annual mammograms between the ages of 25 and 30, or 10 years earlier than that relative was diagnosed. So if mom was diagnosed at 38, we recommend that they start at age 28 with annual mammograms, for example. Okay, now MRI. Where does MRI fit in? So this is what an MRI looks like. This is just one slice. Here's the heart. This is the aorta. This is the right breast and the left breast. It's kind of reversed from where you'd think they'd be. And this is a little cancer. So when we do an MRI, we inject contrast into an IV. So it goes through the vein, into the heart, and then throughout the body. And the contrast is taken up by cancers more than the background breast tissue. So that's what it looks like. And this is something that was not visible on a mammogram. So for MRI, we recommend that patients, again, that high lifetime risk subsegment of the population, we recommend that they get annual breast MRI in addition to mammograms. And we start those annual breast MRIs between the ages of 25 and 30, in addition to their regular mammograms. And if a patient has already had breast cancer, especially if they were young, like under the age of 50 before they were diagnosed, we also recommend that they add annual screening MRI in addition to mammography. And the same goes for having had a history of atypia or lobular neoplasia on a biopsy. For these very high risk patients, there's no reason to add screening ultrasound in addition to mammography. It really isn't adding much. The MRI is going to find all those cancers that would be on ultrasound and many more. So no reason to do all three. You don't need to do mammography and ultrasound and MRI. It's really just MRI and mammograms for these very high risk patients. Okay, so quick summary. Average risk, annual screening mammograms starting at 40 for everyone. Intermediate risk, so for instance, just dense breast tissue. We recommend annual mammograms starting at 40, and you can think about adding screening breast ultrasound if there's no other risk factors. And then for high risk patients, again, we start annual screening mammograms around the age of 25 or 8 years after completing radiation therapy. If you've had radiation before the age of 30, personal history of breast cancer or atypia, we recommend annual screening mammograms from there on out, from the time of diagnosis. And if there's a first-degree relative with a history of premenopausal breast cancer, we again recommend mammograms beginning between the ages of 25 and 30 or 10 years before that relative was diagnosed. And then we add screening MRI for these patients beginning at the age of 25 to 30. Okay, and that's all I have. Thank you.
Thank you, Dr. Thomas. We're going to pass the baton to Dr. Julia Feniger.
I'm Julia Feniger. I'm a GYN oncologist with Legacy. I think either Christine or Jen, you guys have my slides. I can pull them up to share my screen as well.
I can do that for you. Just give me 1 second here.
Great. So I'm a gynecologic oncologist with Legacy. And, you know, sometimes I get the question, what exactly is that? So we do residency training in obstetrics and gynecology. And then we do an additional 3 or 4 years of subspecialty training, learning how to perform surgery and give chemotherapy to women with gynecologic cancers. So cervical, ovarian, uterine, vulvar cancer, even though it's fairly rare. And we also do a fair amount of surgery on patients with complex gynecologic conditions like fibroids or endometriosis. And so our scope of practice is somewhat broad. And, you know, we don't end up doing a ton of cervical cancer screening in our practice, but you know, we do see patients that have cervical precancers or cancers that can certainly be, you know, prevented, as I'm going to talk about today. And thank you. And I might just say next slide, Jen. Okay, perfect. So I'm going to talk about a couple of things tonight. I'm going to talk about what HPV is, because it's crucial for kind of understanding cervical cancer and screening for it, why it matters, what a Pap test actually is, who gets screened and when, what you should do if you have abnormal results, and then finish about how to reduce your risk of developing cervical cancer altogether. Next slide. And so just for a quick anatomy review, I think this is, you know, something that not all women kind of understand exactly where everything is. So the cervix is the tissue at the very bottom part of your uterus, your womb. And the way that we can access it is because it's at the very top of your vagina. So if somebody sees your gynecologist or family practice doctor, they can insert a speculum to be able to see the cervix and to be able to collect some cells from it in order to screen for cancer. Next slide. And so almost all cervical cancers, so probably like 95 to 98% of them, are caused by HPV or human papillomavirus. And human papillomavirus is ubiquitous, meaning that like 85 to 90% of the population gets infected by it at some point. And the good thing is that our immune systems clear the virus in like 90% of cases. But in the patients whose immune systems or bodies don't clear the virus, it can get integrated into the cells in the cervix and develop precancers and cancers, although those are much less likely. Next slide. And so there's the part of the reason that screening works is there's a really long lag time between when somebody gets infected with HPV and when they would actually develop a precancer or a cancer. And it usually takes like 25 to 35 years from the time that somebody gets infected with HPV. So in many cases, that's in someone's late teens or early 20s to the time that they would actually develop a cancer. So we have a lot of opportunity in between that time in order to treat and detect precancers. Next slide. And so cervical cancer screening is important for a couple of reasons. One is that it can save lives and does save lives, but only if patients actually get tested. As I alluded to, it can find HPV and other cell changes or precancers years before they become, or decades even before they become a cancer. And if you remove the precancer, patients are less likely to get cancer altogether. And the other important thing is that it can find cervical cancers when they're at an early stage, when the treatment is less extensive and more likely to be successful. Next slide. And so HPV does not just lead to cervical cancer. So there are a number of HPV-related cancers, and their incidence is actually increasing, partially because we don't really have great screening tests for these types of cancers. And so since the beginning of this century, there's been more than a 2% increase in HPV-related cancers every year. And we think that in a couple of years for women who are 55 and older, anal and rectal cancers will actually be more common than cervical cancer. Next slide. And we don't do as good of a job in terms of screening as we should. So there are probably a lot of reasons for this, but even between 2005 and 2019, the percentage of patients that were overdue for screening went up from 14 to 23% in the US. So there's definitely room for us to do better. Next slide. And so there are two types of tests that I'm going to talk about in a little bit more detail. So one of them is called a cytology test, and the other one is actually a test for the HPV virus. And they get collected basically the same way. So someone goes to the doctor, their provider inserts a speculum, which is that metal thing, and it sort of opens up at the end of the vagina so you can see the cervix. And then they either will do like a swab or a scraping, kind of depending on the specific instrument, which samples the very outside of the cervix and then a little bit on the inside part of it. And then the cytology test looks at the cells taken from the cervix under the microscope. And then the HPV test is taken from the same sample, and it looks at types of HPV or strains of HPV that are most likely to cause cancer and precancer, and then reports those kind of out as positive. Next slide. And so screening is a little bit different, kind of depending on what age you are. So patients younger than 21 years don't need to get screened. From ages 21 to 29, we typically recommend doing cytology or the cell testing only. And part of that is because a lot of people in their 20s are going to get infected with HPV, but their body is most likely to clear it. And so we don't test for it because we would find it all the time. And it doesn't really have a huge outcome or impact in terms of risk because it's going to go away. But then, when women or patients get to age 30 to 65, then we start incorporating the HPV testing because if the HPV is there, it's probably been around for a little while. And then we start to worry about these precancers or cancers developing. Now, if somebody has had a prior hysterectomy, so that means getting their uterus and their cervix removed, and they don't have a history of precancer, then they don't need to get pap smears anymore. But if they do have a history of precancer or cancer, then they still have to get kind of a similar sort of test at the top of their vagina for 25 years. So you're not quite done with it, but it depends on who you are and what your history is. Next slide. And so because we're doing this cytology testing with the cells, and then we're doing the HPV testing, and there's like 3 different boxes your HPV test can fall into, it can get kind of confusing really quickly. Next slide. And so, there's your providers actually have kind of a set of guidelines that they use, and there's actually an app that we use to try to make sense of what to do about the abnormal results. But in general, if something isn't perfectly normal, based on what your prior results are and your risk, based on if you have some condition like HIV or something else that compromises your immune system, you basically go down one of 2 paths. So if you have a low risk of having a precancer either now or within the next 5 years, then you just get another screening test either a year later or 3 years later. But if you have a higher risk of having a precancer right now, the recommendation is either to get something called a colposcopy, which is basically a way to look at the cervix under kind of modified microscope, basically after putting some dilute vinegar on it. And anything that looks abnormal gets biopsied or a sample gets taken of it. And if it's an even higher risk, then the recommendation is for something that's called an excisional procedure that basically removes a portion of the outer part of the cervix. Next slide. And I think this is really important for any screening test, is that even if you're up to date with your screening, if you have symptoms that would be concerning for cervical cancer, so you have abnormal vaginal discharge or bleeding after vaginal sex, a very persistent, strange vaginal odor, or unexplained pelvic or abdominal pain, you should see your healthcare provider so that they can do an exam and take a look. Next slide. And so there are other things, just like Dr. Thomas was saying with breast cancer, that increase your risk of developing cervical precancers and cervical cancer. So as I alluded to, HIV or other conditions that weaken your immune system are more likely to have HPV infections stick around, and then also more likely to actually develop cancers and precancers. As a result, these patients need to get screened a little bit more carefully, and they don't stop at age 65. And smoking, just like breast cancer, increases your risk, although quitting or cutting back can really reduce your risk of developing a precancer or cancer. And then there are a few other risk factors that aren't necessarily things that you can do a lot about, but they just sort of exist. So patients who have a long-term use of birth control pills, having 3 or more children, and multiple sexual partners have a higher risk. But I don't say that it's not meant in any way to be judgmental. It's just sort of the way the numbers look. Next slide. And so I wanted to end on a positive note, because when we talk about screening, we're kind of trying to pick up things that are abnormal related to the HPV virus and changes that it can cause in the cervix before it turns into a cancer. And so that kind of falls into number 1 and number 2 on the slide, which is getting screened and then minimizing your risk factors, which mostly just means quitting or cutting back on smoking if you are a smoker. But then there is a really exciting opportunity to do something called primary prevention, which is to, really significantly reduce your risk of getting a precancer or cancer altogether with the HPV vaccine. So in the US, we have something called Gardasil, which covers 9 common strains or types of HPV. It's approved regardless of gender. And we recommend that, kids start getting vaccinated as young as 9 years, but usually starting around 11 or 12. And if you start getting vaccinated before age 15, you only have to have 2 doses. You can't completely opt out of cervical cancer screening yet if you've gotten your vaccination, but I think that may change in the future. And then patients who have not gotten vaccinated when they were younger, that are aged 27 to 45, have FDA approval to get vaccinated, but instead of kind of making a blanket recommendation that everyone get vaccinated if they haven't been already, recommend discussing it with your healthcare provider. Next slide. And I just wanted to end on, one thing is that, HPV vaccination does prevent cervical cancer. We have really exciting data that's coming out over the past couple of years. It lowers the risk of developing a precancer and a cancer. And there's more protection from either of those things if someone is vaccinated at an earlier age. So I just wanted to end with this very short video, sort of highlighting the connection between vaccination and cancer prevention and uptake of screening. You just click on the link, Jen.
What one is the link? I don't.
In the video or on the video, it might work.
Okay.
And this is from the CDC website, so you can also just put a link in the slides when they pop up.
Yeah, it's not showing as a link.
Okay, that's fine. It's a short video just about somebody who is diagnosed with cervical cancer. And it really highlighted for her the importance of protecting her kids, so that they would never have to go through what she had to go through in terms of the stress and the pain and the difficulty of undergoing treatment. Next slide. And so I just want to thank all of you for your time and attention. As Christine alluded to at the beginning, September is Gynecologic Cancer Awareness Month. And so, I think doing everything we can to educate ourselves about what screening looks like is probably kind of the first step to improving uptake and understanding kind of what's happening when you get screened too.
So thank you to you both, Dr. Feniger and Dr. Thomas. I do have a couple of questions. I'm sharing the love. There's questions for both of you. First off, Dr. Thomas, you shared information about breast cancer risk evaluations for those at higher risk, specifically African American women and those of Ashkenazi Jewish descent. Are there any specific recommendations or considerations for Latina women?
No, not broadly, just on an individual basis. Yeah. So talk to your doctor about your risk factors by age 30, ideally. And if you don't have any significant family history or any of those other risk factors, like a personal history of cancer or a mutation, then we would just recommend starting at age 40. And it's the same for Ashkenazi Jewish and African American women too. If they don't have any other risk factors, then we just recommend screening at 40. It's just we really want to highlight those groups as having an elevated risk of BRCA1 and 2 mutations.
Okay, you're not off the hot seat yet. Another really great question. How would someone know if they have dense breast tissue prior to getting a mammogram, like if they're in their 20s, say late 20s, early 30s?
You can't. You won't know until you get a mammogram. Yeah. Unfortunately, that's the only way to know. So if you're average risk, you actually won't find out till you're 40. Yeah.
Okay, yeah, really good questions from the audience. Thank you. Okay, Julia, it's all you.
Okay.
One of the questions that I got from the audience member is how is cytology different than a pap smear?
So that's a really good question. There's a little bit of history to it. So the person who developed the pap test was Dr. Papanicolaou, or PAP. And so he did it as it's a cytology test. And so the pap test is the same thing as cytology, but now we have that and the HPV test that sort of make up how the screening is done. And it's a lot better that way to have both, all of that information.
Nice, thank you. And then another question for you. I'm sure this isn't the first time that you've considered how you would approach parents who are skeptical or afraid of introducing the HPV vaccine based on the ages it's recommended. And what kinds of things do you go over with them, and how do you address that?
Yeah, so I think, HPV vaccination, I think of it sort of pure and simple as cancer prevention. We have good evidence that you can protect your kids more, like to a greater extent, if they do get their vaccination and risk of a lot of different types of cancer. And, I think that at least when the vaccine came out, there were, concerns among parents that, maybe it was going to make their kids, more promiscuous or more likely to have sex earlier or feel like it was okay. And I don't really think about it that way at all. And there's actually very good data that it doesn't, getting the vaccine does not change a kid's behavior. The vaccination is cancer prevention, pure and simple.
Excellent, thank you. I love the audience questions, yay. Okay, here's another one from one of the participants. Is dense breast tissue hereditary? And is there a likelihood that you would have it if your mom or your grandmother did?
Yes, but I couldn't really give you like an exact percentage or like what the risk is of having dense tissue if your relatives did. But yes, there is some hereditary component, and we just don't know exactly what it is.
Okay, thank you. Okay, I'm just making sure. Okay, kind of like last call. Anyone has a burning question that they want to make sure that they ask before we wrap up, type away. And if not, I'll give it a few moments here. But what I do want to say and recognize is everybody's investment in time and their commitment to learning about how to protect themselves from cancer, to be informed consumers about their own health, and not only for themselves, but for their loved ones, friends, family, and beyond. So I can't thank you enough for the investment that you made in you tonight. And there is another question. Does a PAP include an HPV test?
So usually it does, and it should if you're between the ages of 30 and 65, but your provider has to order it. When they collect the sample, they have to order the HPV test as sort of a specific component. But it all gets collected at the same time. And so, if you're looking at My Health or something if let's say you've gotten a PAP test, there will be two different reports that will come up. There will be a PAP report, which is the cytology report, and then there will be an HPV testing report. And you'll need to follow up with your provider about what exactly the significance is of those two things. It's easy if the HPV test is negative and the cytology is normal. But if it's anything other than that, then talking to your provider about what the next steps should be is crucial.
Nice, thank you. Okay, well, everybody, I'm giving you, 15, 20 minutes of your fall equinox back. Again, thank you for your time. We have recorded tonight's webinar. It will be posted in the future on legacyhealth.org's website for others to watch, you to review. Thank you to the physicians who presented tonight. And lots of kudos to both of you for the information presented, how valuable it was, how appreciative folks are of having received it. You're being showered with thank yous. And so with that note, have a good evening, everybody. Take good care of you and those you love.